The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to the webinar. I'm Andrew Capehart, lead staff person for the APS Technical Assistance Resource Center here at WRMA Incorporated. I'll be moderating the webinar today. We're going to be hearing about some promising practices from Massachusetts, and I'll introduce our speakers here in just a moment. A quick disclaimer about today's webinar: the National Adult Maltreatment Reporting System and the Adult Protective Services Technical Assistance Resource Center is a project the U.S. Administration for Community Living, Administration on Aging, Department of Health and Human Services, administered by WRMA Incorporated. Contractors' findings, conclusions, and points of view do not necessarily represent the federal government. So we just need to say that for you guys before we get started. We'd like to tell you a bit about our APS Technical Assistance Resource Center. We're here to help APS programs in any way that we can. Just reach out to us. Contact info for the center will be displayed at the end of this webinar. Consider joining our APS TARC listserv. More information about the listserv is attached to the handout section of your GoToWebinar control panel. So you can download some info about that listserv if you're interested in joining us. A bit of housekeeping before we get started. This session is being recorded and will be posted to the web at a later date. Anybody who registered for this webinar will be made aware of when it's posted online. That includes all of you guys. You may use your telephone or your computer to connect to audio. Just select the option you prefer on your GoToWebinar control panel. An example is displayed here of where you can make that selection. You can switch back and forth if you need to. All participants are muted for this webinar, so there's no need to mute your line. If you have any questions of our presenters today, simply type them in the questions box. An example of where to type is posted on this slide, and it's circled here in purple. You don't have to wait until we pause for questions to submit your questions. You may type them anytime, and I'll relay them to our speaker when it's time for questions. So again, if our speakers are doing their thing today, do you think of a question, go ahead and type it in and hit enter, and when it's time for questions, we will relay that to them, so you don't have to wait to do that. So now we'd like to administer a brief poll to you guys. Tell us a little bit about which category you identify most with. And I'm going to launch this poll, so it should pop up on your screen right now. So go ahead and click on your screen and tell us which of these categories most fits for you. We'll leave this up for a few seconds so that we have a good idea of who our audience is. I'm looking at the live results come in. Looks like the majority of folks are in social services, whether that be APS or other social services professional. We'll give it just a minute, and then I'll close the poll out and share that with everybody so you can see the result. Still got a few more votes coming in. Give it about 5 more seconds, and then we'll close it out. All right, I'm going to share those results with everybody. So it looks like there's quite a few folks that consider themselves other social services professionals. So you work in social services, but you're outside of APS. Quite a few, 22% are APS professionals, and we have medical legal folks and other folks that consider themselves other. So thanks for doing that poll for us. I'll take a brief moment to introduce today's speakers, and then I'll turn things over to them. We have Mariah, Freark, and Jaime Suvak on the line with us. Mariah is Assistant General Counsel, and Jaime is the Sexual Assault Response Unit Manager at the Massachusetts Disabled Persons Protection Commission in the state of Massachusetts. Both were intimately involved in the grant, and they'll be discussing all about the grant today. We're lucky to have them on the line, preparing or giving some of their wisdom to us. So thank you both for being with us, and I will now turn things over to you and make you the presenter.
Awesome. Thank you, Andy.
Certainly.
All right. Show my screen. Okay. Let me get squared away here. Oops. We're not there yet. Hi, my name is Mariah. I am Assistant General Counsel with the Disabled Persons Protection Commission. So before we jump into the specifics of our 2015 ACL grant, I wanted to give everybody an overview of the state system here in Massachusetts. Oh, there we go. Move that out of the way. Perfect. So Mass is a bifurcated adult protective services system. So my agency, the Disabled Persons Protection Commission, has jurisdiction over adults with disabilities between the ages of 18 and 59. The other big piece of the APS system here in Massachusetts is the Executive Office of Elder Affairs, and they pick up everybody over the age of 60, whether they have a disability or not. We've got almost 45 FTEs to cover the state, and a couple of other things about our program that we think are interesting and that we like to share are we have a state police detective unit, which is assigned to and co-located with the Disabled Persons Protection Commission, and that allows us to collaborate really effectively with law enforcement. We have a sexual assault response unit, which you'll learn more about in a little bit. And we are in the midst of finishing our first year of either, I can't remember if it's 2018 or 2019 ACL award. I get confused about my fiscal year versus the federal fiscal year versus the calendar year. But like a lot of you, we are working on increasing our ability to participate in NAMERS and using that money for technological innovations. So for our ACL 2015 grant, one of the questions in putting this webinar together that was asked of us was, how did you guys even get there? What led to the need for that project? So for us, it started with a phone call to our executive director, Nancy Alterio, a distraught parent whose son had been raped. Her son had intellectual or developmental disabilities, called Nancy and was concerned about her son's decompensation after the sexual assault. And during the course of this conversation, it came out that even though the mother was a psychologist and the father was a psychiatrist, neither parent had considered counseling or therapy for their son who had been sexually assaulted. So Nancy started to wonder whether this was an isolated case or a systemic issue. She did an internal review of cases here at the Disabled Persons Protection Commission to look at whether protective services recommendations were made that sexual assault victims be given access to trauma services like therapy. And what she found was the recommendations were sometimes made, but they were frequently not executed. And then at the same time, there were other issues running parallel. One of them was the rape crisis centers statewide had done a needs assessment and had identified serving people with disabilities as a need where they felt they could use some more training and guidance. We were also made aware from the rape crisis centers and from the State Department of Developmental Services, who would contact the Disabled Persons Protection Commission looking for referrals for therapists or counselors who were knowledgeable about treating people with intellectual or developmental disabilities who had also been sexually assaulted. That's, you know, it's a dual competency and not everybody's equipped to do that. So we worked with the Department of Public Health. In Massachusetts, the Department of Public Health oversees all of the rape crisis centers. So the Department of Public Health and the Department of Developmental Services conducted a statewide survey to find all of these therapists who were dually trained in serving this kind of intersecting population of people with intellectual and developmental disabilities who had been sexually assaulted. And we came up with two names. So all of this led to, you know, we knew anecdotally, including what we were seeing within our own agency, that people with intellectual and developmental disabilities were not getting access to trauma services like counseling after a sexual assault. And so we also had the data to show that this was happening, in addition to the research that's out there that confirms that people with disabilities suffer from trauma. So that was how we came to a goal of increasing access to victim services for people with intellectual or developmental disabilities who are victims of sexual assault. That's a huge goal. So we broke it down a little bit more and we identified a realistic and achievable starting point of increasing access to the rape crisis centers specifically. We did this by pulling a team together. We actually started pulling this team together during the grant application process, which ended up being really helpful and really great because by the time we got the award, metaphorically speaking, there was gas in the car, there were keys in the ignition, like we were ready to start. So in addition to the Disabled Persons Protection Commission, we had the Department of Public Health, we had Rape Crisis Center representatives from each region of the state, we had self-advocates at the table as well as the State Department of Developmental Services. Riverside Community Care provided consultation and guidance on the clinical piece of these issues. We worked with the sexual assault nurse examiners, victim compensation from the Attorney General's office, and then a statewide domestic violence coalition called Jane Doe, Inc. So we put together a really formidable team, and we did a lot of really cool stuff, which I will tell you about in a minute. But we did hit some challenges in trying to increase access to rape crisis centers for folks with intellectual and developmental disabilities. And one of the biggies was we were kind of working with two separate worlds that didn't really intersect. So you had the Rape Crisis Center victim services people, and then you had the people who were working for service providers for people with disabilities, but they didn't know much about each other. So, you know, somebody from a rape crisis center doesn't know what a service coordinator at the Department of Developmental Services does. And, you know, at the same time, that service coordinator doesn't really know what a rape crisis center provides. So just introducing these two worlds to each other and helping them understand what they do, what they have in common, how they can work together, I don't want to say it was a bad challenge. It was actually a great challenge, and it ended up working out really well. But one of the other issues that came up from working with and trying to bridge these two different worlds were philosophical differences. Because for rape crisis centers, they have a really strong emphasis on privacy, and service providers for people with disabilities have an emphasis on a team and a multidisciplinary approach. So that was something that we had to work to kind of translate and bridge. We also had to kind of help to encourage a culture shift as far as the accessibility of rape crisis centers. There were a couple of physical accessibility issues, but there were more programmatic and attitudinal accessibility issues that we were largely able to overcome. And we had a lot of common ground to help us overcome these challenges. One of the biggies was everybody, regardless of what world they were from, was committed to service. They were committed to serving the population that they were working with. And so once we were able to say, you know, hey, your population includes people with disabilities, your population includes people who have been sexually assaulted, our partners really got on board. Another big piece that helped us really bridge some gaps was everybody was committed to the idea of empowerment. And once we helped the rape crisis centers understand that empowerment might look differently for a person with a disability, that was huge. And so everybody agreed on, we shared a vision that we wanted to increase access to services so that we could increase healing and decrease trauma. We had a ton of successes. These are my next couple slides. So from the 2015 grant, we conducted 4 regional multidisciplinary trainings. We identified regional sexual assault liaisons within all of the agencies that work together. So there is a liaison at each rape crisis center. There is a liaison in each regional Department of Developmental Services office. And we work to update those lists so that people have somebody that they know in their region at an agency that they can reach out to for assistance. The liaisons ended up being a really big deal in helping us disseminate and share information, and in taking information about our project back to their own organizations and kind of helping us build the infrastructure. We created and distributed guidelines for rape crisis centers on best practices for serving survivors who had intellectual or developmental disabilities. I think those are in the downloads for today if you're interested. We established regional learning collaboratives so that people who are doing this work, you know, on the ground, in the field, can meet regularly to discuss best practices, to workshop cases, to talk about trends. We also, there was some fortuitous timing that came up with the Department of Public Health's contract renewal. I mentioned earlier that the Department of Public Health oversees and funds all of the rape crisis centers in the state. And so during our project, all of the rape crisis center contracts came up for renewal, and the Department of Public Health put language into their specific language into these new contracts saying, hey, if you want to continue to operate, or if you want to begin to operate as a rape crisis center in Massachusetts, you need to be active about serving people with disabilities. So those contracts, or those changes included allowing for mobile services, which is huge because meeting people where they are really increases access to services. Transportation can be a big issue for people with disabilities, especially in the more rural parts of the state. The contracts also allowed for additional sessions and for longer sessions, which again is really important and valuable for people who have intellectual or developmental disabilities because they might need a little more time to process or communicate. The Department of Public Health also mandated that all of the rape crisis centers receiving contracts have training on the guidelines for serving survivors with intellectual and developmental disabilities. And so that's what we did within the confines of the 2015 ACL grant, but it really did set the groundwork for continued growth and momentum. As our next step, we sought federal VOCA funds to keep going, and we created the Sexual Assault Response Unit here within the Disabled Persons Protection Commission. Jaime's going to talk more specifically about that in a couple of minutes, but we offer what we call navigational services to help people learn about and access victim services throughout the state. We established a peer support leader program, and our peer support leaders are doing great work. We contracted with Massachusetts College, the William James College, to provide clinical matching services. So these are services for people who are seeking a therapist, and then a list of therapists who take your insurance and are geographically located, are accepting new patients. So that has been part of our next step. We convened an advisory council for the Sexual Assault Response Unit comprised of influential and passionate members. We were very deliberate in the folks that we asked to join the council because we picked people, in organizations that we have strong relationships with, but we also wanted to expand out and identify agencies, state agencies or nonprofit organizations that we wanted to have a stronger partnership with. So we were able to seek out decision makers to help influence change within their own organizations and kind of increase the ripple effect from the grant. Just as a side note, for those of you who have or who are pursuing VOCA funding, for us there was a requirement that we needed to use volunteers, and so having a volunteer advisory council was a great way for us to meet that requirement. Some of the sustainability that came out of our grant we saw happen on a system level. So I mentioned earlier that the Department of Public Health had expanded their services and made changes to the Rape Crisis Center minimum requirement. So we hit that from both the top down with the contractual requirements and the bottom up with the learning collaboratives, enabling people who are doing the work day to day to connect with each other. We also came up with a memorandum of understanding that solidified our commitment to expand access to culturally accessible, multidisciplinary sexual assault services for adults with disabilities throughout the state based on self-determination and self-advocacy. So in addition to the Disabled Persons Protection Commission, that MOU was signed by, and that commitment was agreed to by every rape crisis center in the Commonwealth, as well as by the Victim Rights Law Center, which offers civil legal assistance to survivors of sexual assault. Other changes that we saw on a system level were increased access to rape crisis centers by persons with IDD. This was huge. This was such a great proof that our project made a difference. There were statistics that were recently released that showed that out of rape crisis centers nationwide that receive VAWA funds, rape crisis centers from Massachusetts had the highest number of service recipients who self-identified as people with disabilities. So that was really cool. We saw increased access to the forensic STAIN exam within the 5-day evidence collection window. The State Department of Developmental Services remained, they started out and they continue to be a very active participant. They're still a key partner to this day. They've appointed one of their higher level administrators to serve as one of the department liaisons. The department commissioner is a member of the Sexual Assault Response Unit Advisory Council. The department provided training on sexual abuse for all of its staff, and it also distributed a recommendation to all of its providers to take sexual assault victims to a SANE designated hospital, even if that's not the closest or the most convenient hospital. The Department of Developmental Services appointed regional liaisons and supports the regional liaisons in attending the learning collaboratives. And the department has also committed to hosting learning collaboratives by offering space to, again, give people from the two worlds the ability to continue to connect and work together, even though the grant has finished. So the last sort of really big picture system changes are, we worked with the William James College Interface Project to try to remedy that issue I mentioned earlier of therapists who are cross-trained and dually competent in serving people with intellectual and developmental disabilities and serving people who had been sexually assaulted. So the William James College helped us identify therapists who were interested in being cross-trained and being able to serve this intersecting population. And so we recently conducted a 2-day training on how to modify therapeutic modalities to accommodate people with disabilities. So now the list of people who have the dual competencies is up to 90 and counting, which, coming from a population of 2, we're really proud of that. We're also really excited about the first annual peer support convening that'll be happening at the NAPSA conference next month. That'll be a meeting of self-advocates, the DPPC, and other stakeholders to develop a national vision and a plan to address sexual abuses against people with disabilities. One of the other cool things that came out of this is there's now a VOCA-funded civil legal aid initiative here in Massachusetts, specifically focusing on meeting the legal needs of people with intellectual and developmental disabilities, not just related to sexual assault, but whatever else they might need. And this initiative involved the creation of guidelines for the civil legal aid attorneys who are going to be working with people who have intellectual and developmental disabilities. And those guidelines are based off of the guidelines that we drafted for rape crisis centers during our 2015 ACL project. So that's a pretty quick overview of our DPPC's ACL 2015 project and what we've done to sustain since then. I want to hand it over now to Jaime Suvak, who's the manager of the Sexual Assault Response Unit, so she can tell you more about what they do and how they do it.
Thank you, Mariah. So as you can all tell, there has been years of very thoughtful work put into building sustainability and to building this unit, and so I've had the privilege of overseeing it since it is incepted 2 years ago. And over those 2 years, we went from the question of, okay, we know why we need to do this, but how do we do this, to really looking at what we've been doing over the last 2 years and making a lot of really exciting and interesting discoveries about this work and how we can improve access for persons with disabilities. So our goal is to increase access to trauma services for individuals with disabilities who have experienced sexual violence. We know that when folks do not get access to services, a domino effect can occur, and it can affect medical, emotional, and daily living needs. So our navigation, which I will talk about in a few minutes, can issue spot and address concerns before this domino effect has a chance to occur. By utilizing our position at the Disabled Persons Protection Commission, the Sexual Assault Response Unit is situated to be the most effective in responding to sexual violence in the communities it serves. Because we receive all of the cases reported to DPPC, which is at about 1,100 annually at this point of sexual abuse cases reported, and that's up about 27% from 2 years ago since we started, we are able to screen cases that require immediate attention and provide timely access on all cases. So one of the things that we're very proud about is that since we see all of the cases coming in, and we screen them, if a case has happened within 5 days, we are able to immediately outreach to that survivor through their providers or them directly and let them know about the Sexual Assault Nurse Examiner program and the time-sensitive information about medical needs. We're also able to utilize the agencies that have been developed over years of collaborations to increase trauma-informed care and proactively enhance services. The Sexual Assault Response Unit is comprised of 4 main components. Our regional navigators provide free mobile direct services statewide to provide access to trauma services. Peer support provides peer-to-peer support and community outreach statewide. I'm going to talk about navigation and peer support in a minute, but I wanted to also mention some things about Interfaith Clinical Matching Service and our advisory council. Again, I know Mariah had just talked about it, but I want to expand a little bit about what it means to have a clinical matching service for these folks, because most of the people that we are encountering, they don't have access to trauma therapy. They're in systems where they have therapy. They've had therapy for a long time. They've had a lot of support and services, and introducing trauma therapy as something new and of use has been a real benefit to folks. And using the clinical matching service, which again has gone from 2 to almost 100 qualified providers who will work with our folks, has been statewide, has been incredibly useful for folks who are looking to really process and heal from trauma. Behaviorally, there are a lot of things that happen when folks are abused or have experienced a sexual assault, and sometimes those behaviors are problematic, and that causes issues in group homes, and it causes issues in systems. And one of the things that we've been educating folks on is that through trauma therapy, some of those behaviors can be extinguished as well as healed. And as Mariah said, we have a fantastic advisory council that with leaders in the field that have done tremendous work already in their own relevant areas about sexual violence in persons with disabilities. So these facets work together to inform one another and to support the mission of increasing access to trauma services. And when I talk about increasing access, it's really important to note that I'm talking about meaningful access, and we're talking about making sure that folks understand what the services are that they can use, how to use them, and the best way for them to get the most effective treatment out of them. So what do? Our navigators outreach immediately on all cases that are reported within the 5-day window and could benefit from the Sexual Assault Nurse Examiner program. Due to the time-sensitive medical attention that can be sought, it's imperative to get this information to survivors as soon as possible. For the fiscal year of 2019, we were able to do almost 100 of these outreaches to folks who may not have known about Sexual Assault Nurse Examiner or had access to that time-sensitive medical care. Navigators outreach to agencies and providers to ensure that survivors are getting the best response when they disclose sexual violence and are able to access trauma services. So again, in our fiscal year 2019, we did outreach to 167 providers statewide and reached 3,400 people. And we have provided 232 clients with over 1,000 resources and referrals over the last year. Navigators work directly with survivors, their supports, and their providers, reducing re-victimization and increasing resiliency. So over the last year, we worked with 370 survivors. They received individual advocacy from our unit, which includes psychoeducation, resource referrals, general support, and provided 2,500 occurrences of individual advocacy. What's interesting to note here is the unit staff spent over 30% of their time, their work time working with survivors, in collateral time, including organizing transportation, accommodations, and consultations to providers. So in direct service, this is quite a high number, and that's of note. And recently, we have been going to the providers that have been utilized by folks coming through our unit and checking in and asking them, now that they're seeing more folks and that they have folks using their services, what they're struggling with now. And I think that the setup that everybody had in the beginning really gave a great foundation to begin this work. And so we're in phase 2 of looking at longer term and looking at more of the intricacies of doing the work with persons with disabilities. So our Navigators Empower Survivors. They provide information and they conduct a full needs assessment that's inclusive of the survivor's needs and wants to help understand and provide the best services for them. They provide access, and access means a lot of different things. Navigators present the service options and help the survivor to utilize those services, increasing meaningful accessibility and effectiveness. They provide education. Psychoeducation is offered and discussed with survivors and their supports to help the team understand and support the survivor the best way they can. This support can also increase utilization of services and the impact of trajectory of healing. And an example of that is we work closely with Impactability, which is a program that serves persons with intellectual developmental disabilities around safety and sexual health, and do lots of trainings. And we have really worked to develop a close relationship with the folks providing that service. And because of that, many of our survivors, of our clients that come through our unit, have been able to be offered and have used that service very effectively. We also rely heavily on a multidisciplinary team of liaisons, which Mariah had mentioned, and other state agencies and victim service organizations. So it's through these liaisons and committed connections that the unit is able to provide timely and accessible and effective services. We have direct access to services for victims of sexual violence who normally would have to go through the general intake process for all of these services. And that in and of itself is a huge obstacle for many people. So we're able to work with all of the different multidisciplinary teams and have them have a more direct line of access. In 2 short years since the unit was established, we've also learned that in addition to the multidisciplinary liaisons, there are other important aspects to the work. Teamwork is essential within our unit, within the Disabled Persons Protection Commission, and statewide. We utilize everyone that comes in contact with the victim and can provide services to this victim for each case. So we are pulling together any supports possible in any area that's needed, and working together to make sure that what is happening and what is being provided is what the victim wants and is being provided effectively. Issue spotting. So there are so many assumptions made with persons with disabilities, assumptions made about what they need and how to provide it. However, these are not always congruent with what the survivor actually needs and wants. So doing a detailed and thoughtful issue spotting with each survivor really allows them to lead their trajectory of healing. Informing and supporting client, family, and team. So we are only with survivors for short periods of time, and we are not in their daily life, and lots of folks have many supports and providers in their life on a regular basis. So having consistent information going to the client, the family, and the team is essential in creating safe and supportive environments and conducive to healing. And connection. So we have been the go-to for survivors and their families, and that's been critical in reducing confusion and delays and increasing access to services in an effective manner. And one of our navigators was described as the mom of a survivor said that it was, in working with her, was like having a Christmas present, because she always knew that she could contact her and she would be able to help, and felt like she was always her first person to go to. The navigation team also connects the survivor to the peer support team if they're interested. The navigators work closely with the peer support team on both outreach events and direct service. So I want to talk to you a little bit about our peer support program. We have 2 incredible peer support leaders, Patty Quatieri and Leigh-Ann, who I will introduce you to via their stories in a couple of minutes. And they are persons with intellectual and developmental disabilities who are survivors of sexual assault, and they have been with this project from the ground up. They've been providing essential leadership and development for the program and for services and for education and outreach. They have done everything from adapt some of the SAMHSA trauma-informed care handouts for us so that they are more accessible to their peers, to speaking at large conferences. And I think Mariah talked about NAPSA and the work that is going on there this year. So they ensure that survivors have an opportunity to speak with a peer, which is essential in trauma-informed care for sexual violence, and really allows the most choice for a survivor to decide who they would like to talk to about this and who they think could be helpful. They also provide an opportunity to look at healing because they can share their own path to healing with their peers. They're learning how to co-facilitate healing groups through our connections with the local rape crisis center. One of our peer support leaders has been developing a healing group for her peers and will co-facilitate that. They share their stories. They share their stories for advocacy, for education, and for healing purposes. And they educate providers on trauma response and care. So I'm going to tell you a little bit about each of them and what they've been up to. So this is Leigh-Ann. And Leigh-Ann says that as a survivor, she's taught to speak up for herself as well as advocate for herself. She helps others as much as she can, and she's stronger because of it. Her job highlight is creating a self-care bingo, and she promotes it and books her own engagements across the Commonwealth. And this is an example of a bingo card that she has created. It's a way for her to engage her peers around self-care, and we are using it as outreaching about our unit as well. So she has been single-handedly across the state doing self-care bingo with her peers. And this is Quatieri. And she is a person who advocates for people with disabilities, and she thinks it's important that they know their rights, have choices, and are safe. And her job highlight right now is creating the National Peer Support Network at the next NAPSA conference with her co-presenter, Kecia, who is another self-advocate from California. And there's a picture of Patty and Kecia. So I wanted to give you all an example of two of the cases that we've encountered over the last couple of years to really give you a sense of what we do in the unit. So a 20-year-old individual with a developmental disability reported to her primary care doctor for a medical appointment. It was discovered that she was 4 months pregnant at that appointment. The client disclosed to her doctor that she was sexually assaulted by a male acquaintance at her local park. And before I get into what we did to help in this case, just want to point out that one of the hopes in providing immediate outreach after something is reported is to prevent folks from being pregnant unknowingly and really be able to have them talk with somebody about the possibility of pregnancy after an assault. So this case filed a DPPC report, and the Sexual Assault Response Unit received it. The Protective Service Navigator and myself attended a Sexual Assault Intervention Network, or SANE, interview at the local Child Advocacy Center, or CAC. The Navigator introduced the unit services to the client and the client's father, who was there with her as a support, and the Navigator was able to schedule a follow-up call with the client and her father. The Navigator called the client and spoke with the client's father about setting up a meeting with the Navigator. And the client and the client's father determined that the local CAC was a safe and accessible place for the meeting. That seems pretty simple, but what I didn't tell you initially was that to get to the point of setting up a meeting took about 8 to 10 phone calls to that survivor and just introducing herself and talking about our services and developing a rapport with her and dad, who had been in services at some point and were feeling a little bit jaded by the system. So the Navigator then reached out to the family advocate at the CAC to collaborate with them and coordinate a meeting. And the Navigator met with the client's father, and the family advocate. The Navigator established a relationship with the survivor, which was challenging due to her intellectual disability, trauma experience, memory issues, and father's oversight. The Navigator established a relationship with the family advocate at the CAC, where the survivor felt most comfortable and where dad felt most comfortable. The client identified that she was interested in preparing for her baby and needed support in doing so. So the Navigator and the family advocate worked together to place referrals and obtain accessible services for healthy families, healthy babies, the local rape crisis center, Community Counseling of Bristol County, and the Department of Developmental Services. The navigator and the family advocate were able to create a plan to check in with the client at each meeting with the sexual assault nurse examiner and the CAC to discuss her pregnancy and get support in understanding the nutritional needs of the client and her future baby. The navigator created pathways and accessibility for the survivor and continues to work with providing support to agencies about how to make their services accessible and meaningful to the survivor. The navigator has been working closely with agencies, working with the family to collaborate and ensure the survivor is receiving services and empowering the survivor to determine which services are working best for her. So we do a lot of checking in with the survivor about all the services that they have been offered, all of the services that they've tried out, what they think is helping. Sometimes there's some adjusting that needs to be done with how services are being offered or how they're being used. And sometimes they just say, this isn't what I want right now, and that's okay. The navigator supported the client and her family in connecting to support agencies and assisting the whole family in the transition to welcoming the new baby into the family. So we really were essential in some of the caretaking of the baby and understanding caretaking. One of the things that became evident with one of the service agencies is that they had a protocol, and at 3 months of pregnancy, they talked about certain things, and at 6 months and at 9 months, and our navigator had to really discuss with that service provider that this survivor needed to be talking about the 9 months checklist at 4 months, at 5 months, at 6 months, and it really needed to look a little bit differently so that she could truly understand the information and integrate the information into being a mom. The second case study, a DPPC report was filed and the SARU received the case. The navigator arranged a meeting with the client and her mother at a local rape crisis center and did a needs assessment. And one of the reasons why we offer another agency for our initial meeting is because we're trying to connect folks with these other agencies who are offering services, and at the same time, we're able to model how to provide services because our navigators are there and we can be inclusive. And sometimes folks say, yeah, I'd like to meet everybody at once, then let me introduce me to everyone. And sometimes they say, I just want to meet with you, and can we move forward from there, which is totally fine. So during the initial meeting, the survivor was able to meet with the local rape crisis center and complete an intake, and was successfully connected to a counselor at the rape crisis center. The survivor was also referred to the district attorney victim witness advocate. The survivor received support from her local safe plan advocate in filling out a restraining order, and the survivor was interested in meeting with the Victim Rights Law Center. So the SARU navigator coordinated a meeting at the local rape crisis center with the survivor, the navigator, the client's mother, and the Victim Rights Law Center. During the meeting, the SARU navigator provided support to the client and assisted the client in completing the intake for the Victim Rights Law Center. And sometimes that is as easy as making sure that that survivor understands the questions in an intake, making sure that the questions are directed to the survivor and they're allowed and able to give their voice and their answers. The navigator and the survivor determined that the Rape Crisis Center was a safe and accessible place for them to meet, and the navigator supported her client during impactability, which is the sexuality and safety training, and coordinated each meeting with impact at the Rape Crisis Center. So the navigator accompanied the survivor to the probable cause hearing to provide support to the survivor and their family, and the navigator ensured that the survivor was able to wait in a private room before the hearing. The navigator advocated for the survivor to be able to see the courtroom prior to the hearing and see where she would be sitting. So with the navigator present to support the survivor and the family, the survivor testified in front of the judge, assistant district attorney, Well, if there's any questions at this time, you can certainly type them into the chat, which we can see. I think we can see it.
record. So I think that we could get you guys one of the
I have a handout on that, exactly what was changed for this particular community.
Yeah, Andy, do you want folks to email you and work through you? Is that the best way to do that? Okay.
Yeah, certainly. Yeah, anybody who's interested in that, we'll make sure that we have that as a resource, and we have the email address for the person who reached out to us about that. So we'll make sure we get you a copy of that.
Great.
All right. Well, our next question, what steps did you take to get the peer support program implemented across the state? And again, what steps did you take to get the peer support program implemented across the state?
Thank you. So our peer support program is definitely still a work in progress. We started with a hiring, and Patty and Leigh-Ann were hired because they've been working on this for so long. They were natural selections for this. And my background is in rape crisis, and so I initiated training for both of them on sexual violence, on things like active listening, on things like peer support. We looked to the Department of Mental Health and their peer specialist program to guide some of the principles of the work. And we looked to best practices in peer support to guide what they could be or should be doing. And from there, we worked with each of them individually to develop their own stories for outreach and their own ideas of what they thought their peers would need and want, and took their lead on that.
Great. Very interesting. All right. We have actually quite a few questions, so I'm going to keep going. How much training on IDD did law enforcement and district attorneys require? Again, how much training on IDD did law enforcement and district attorneys require?
This project didn't focus much on law enforcement and district attorneys. We were really focused on victim services rather than like the criminal justice system. I do know that, you know, kind of separately, our state police sergeant goes out and trains at a whole bunch of law enforcement academies on people with disabilities. And we do have pretty good relationships with the district attorney's offices statewide. We have a memorandum of understanding with each of them about, you know, work cases, adult protective services cases. But this project, that wasn't a focus. So I don't think that ended up being part of the training.
Great, thank you. One simple question, which you may have explained at some point. What is NAPSA? You mentioned NAPSA a couple times.
Oh, that would be the National Adult Protective Services Association. So that's the membership organization for adult protective services workers nationwide. So we have an annual conference every year in August, and so we're all meeting in Denver in like 5 weeks or something.
Great, thank you. Let's see, this is a pretty general question for either of you. What has been some of your biggest challenges, or maybe what's your single biggest challenge? Yeah.
So for our unit, one of the biggest challenges is getting known across the state because it's really difficult to provide seamless access for survivors when you don't know the key players and haven't developed those relationships yet. So we spent a really, really good amount of our time not only just doing initial outreaching, but developing relationships and really using kind of that spider approach where we start with one person and then we get to the next person, we get to the next group, and including as many people as possible in that process.
Sure.
I think, so my role was helping with the execution of the 2015 grant. And I think that for us, the biggest challenge was, you know, coming from disability services, was helping the rape crisis centers really wrap their heads around empowerment looking different for people with disabilities, because traditionally rape crisis has had a focus on sort of you take back your empowerment and you make these choices, and they had a hard time sometimes understanding that people with disabilities needed to have somebody else in the room to be able to effectively do that, even if it were just something as seemingly simple as having a support person in the room with you during a counseling session. So once we were able to help the rape crisis centers understand that, hey, this is still empowerment. This is not taking away anything from anybody. It's actually being more accessible and giving them access to your guys' completely awesome, absolutely necessary services. That really helped us turn a corner in being able to work together.
Great, thank you. Thank you both. Are you writing up anything to make available to replicate this model? Are you the only state receiving such funding? And I'll repeat that. Are you writing up anything to make available to replicate this model? Are you the only state receiving such funding?
I don't know if we're the only state receiving such funding. In our research, I haven't come across any similar program. And we do have write-ups around what we have done and what we do,
the final
for
report
sure.
For the grant project.
Yep. And then right now we are going to start with the rape crisis guidelines, which is a handout here. We are just going to start the process of initiating a revision in addition to that. So that will be coming down the pike soon too.
But if that person wants to email you, we can send them, some of the stuff that we have. And if they're looking for something more specific, we're happy to share.
Okay, great, thank you. Yeah, we'll pass that information along too. What is funding this work beyond the ACL grant? And I think you touched on this at some point, but I'll repeat that. What is funding this work beyond the ACL grant?
What's funding the Sexual Assault Response Unit is Federal Victim of Crime Act funds. The federal VOCA funds are administered at a state level, so each state has their own separate VOCA administrator. And in Massachusetts, that's the Massachusetts Office of Victim Assistance. And they have been a huge and very willing partner. We could not have done any of the Sexual Assault Response Unit work without them. In addition to that, some of this comes under in-kind from the state appropriation of the Disabled Persons Protection Commission. And then it's also a collaboration. So the other partners at the table, are funded through their streams. And then we come together to do what we can that, in our day-to-day jobs.
Great, thank you. This question's a little bit long, so let me repeat it twice. This is from someone in Texas. We have begun working on a more accessible form using visuals and pictures to aid communication and understanding for their rape crisis centers to use to get consent from survivors for a forensic exam that would be legally valid. Are you aware of anything like this in Massachusetts happening?
So the rape crisis...
Let me know if you need me to repeat that. Yeah.
No, I think we got it. Thank you. So the rape crisis guidelines, which is a handout on here, does address some of that question for sure. We don't have legally documents on consent. That's something that I think that the SANE program can answer certainly better than us. And again, if that person wants to contact you, Andy, we can get them in touch with the Sexual Assault Nurse Examiner program. But we have a lot of pictorial guides.
We do, yeah. That was a big part of accessibility.
Great. Will you be expanding your peer support leadership team?
We are currently looking at working with the Department of Mental Health, since we serve all disabilities, in identifying folks from their current peer leadership program who would want to work with us, but it would come out of the DMH and would be supervised through DMH. We are always looking to see if there are peer leaders who are interested in working with us, and over time, I suspect that will grow.
Great, thank you. Could you describe how the empowerment model looks different when working with individuals with IDD, if that's something you're familiar with? Again, could you describe how the empowerment model looks different when working with individuals with IDD?
So traditionally, empowerment, the indicators of empowerment are that it is directly to the survivor, from the survivor, with no other influences, and that making sure that that person understands what their choices are and then being able to choose what they want. With folks with IDD, there are two main differences. One is making sure that people understand what is being said to them, what is being offered to them, what is being asked of them. And a lot of times that requires another person who knows them or some kind of communication accommodation. And that is just not something that is comfortable to a lot of folks, especially rape crisis centers, or what was comfortable, because the tenet of empowerment was really that individual to individual and very private and confidential. The other piece of it, I think, is that making sure that how a person receives services is just as much their choice as anything else. So one of the things that is really important has been really important to folks who have intellectual and developmental disabilities, again, are things like having a support person present, or just having another person who they like and trust. And also the sharing of information is very different. And what is essential when a person has a support team, it's essential that that team knows what's going on with that survivor, because they need to be consistent and they need to be supportive. And again, that can be seen in dissonance to the empowerment model, where it really isn't. And it is truly empowering because you're giving that person the best chance to heal and have a voice with their team.
Wonderful. Thank you so much. Well, it looks like we are out of time. We've come to the end of our session. Thank you so much to Jaime and Mariah. This information was very helpful. You had a lot of great questions today. People are very interested in it. Again, the webinar will be posted. We'll make sure that everybody who's registered for this webinar is aware when it's posted online and available for viewing. If you need to reach out, or if you'd like to reach out, I should say, to the APS Technical Assistance Resource Center, we help adult protective services programs with anything that they need help with. And the contact information is on your screen. There's the web address and email address so that you can reach out to us anytime with whatever questions that you have. Again, thank you, Jaime. Thank you, Mariah, for all this information. It's been very helpful. And thanks to everyone for participating today. Have a great afternoon.
Thank you.
Thank you.